Module 10, the Technique Protocol in Intact Sockets. In this module, I'm going to share with you the use of bone graft from maxillary tuberosity as a bone filler and its clinical application in intact sockets. So from now on, I'm going to focus in the IDR protocol. First of all, the use of corticocancellous particulate bone as a bone filler for intact socket. I will present for you its protocol since the beginning to the end. The protocol is performed in 14 steps. Step 1. Careful assessment of the socket walls. 2. The selection of implant diameter. 3. Minimally invasive dental extraction. 4. Careful curettage of the socket. 5. Implant placement. 6. Construction of the ideal provisional restoration. 7. How to fabricate the ideal emergence profile. 8. The selection of the suitable chisel. 9. Harvesting of bone graft from the tuberosity. 10. Crushing the bone graft. 11. Insertion of the particulate bone graft. 12. Compaction of the bone particles. 13. Installation of the screwed provisional crown. And the last, the suture of the donor area. Step 14. Remember, regardless if we use the IDR protocol for intact sockets or compromised socket, we always leave the suture in the last step of the technique, just to keep this in mind. To follow the protocol, I've selected a very nice clinical case, but very challenging clinical case as well. You can see here, it's a patient with high smile line. You can see the gingival architecture and you can see the teeth. And our goal here is to keep the position of the gingival margin and papillae. Let's follow the step by step. Step 1. Careful assessment of the socket walls. Here the right central incisor is the hopeless tooth. And we have the fracture in this tooth. And through soft tissue enhancement cone beam computed tomography, we are able to evaluate if we are going to face an intact socket or a compromised socket. So remember, we always evaluate the contralateral side. If you make a comparison measuring the distance from the crestal bone to the gingival margin, as you can see in these two CBCT scan sagittal views, you can clearly see that this distance is equivalent. That means that we are going to treat this case as an intact socket. In the CBCT scan of the contralateral tooth, the left central incisor, we confirmed here the periodontal biotype. We have a type 3 periodontal biotype, a thick soft tissue and thin buccal wall. Step 2 is the selection of implant diameter. Remember, we have already discussed about this topic to select the implant diameter always prior to extraction. So we can use both methodologies, the analogical way, using the Stonecast as a reference or a soft tissue CBCT scan. And we can measure the buccal palatal distance of the socket. And remember that the implant must be placed in the palatal wall approach, always expecting a gap around 3 millimeters at the buccal aspect. So in this case, as we have around 7 millimeters of distance, the implant to be selected should be around 4 and the gap around 3. And the ideal position of this implant in the coronal apical direction should respect this protocol. The implant has to be placed 3 millimeters from gingival margin in the apical direction. Through this axial view, I want to call your attention to the right position of the implant, always seeking the palatal wall anchorage. And take a look, not only the diameter of the implant, but the space that we are going to leave between the implant surface and the inner part of soft tissue. Step 3. Minimally invasive dental extraction. Just a quick review. We can use since the beginning. The microblade to promote an intersuccular incision, the beaver's blade. The use of periodontal and mini levers in the palatal wall approach. Using these tools like a pendule, always approach the palatal wall. We never touch with these tools, neither using periodontal or mini levers in the buccal aspect. The traumatic force that is going to be used after this tooth is completely loosened in the socket. But if you are facing strong roots, long roots, it's recommended to do the root section. And in some cases, we can use, since the beginning, a mechanical extractor to promote a delicate extraction. Here, in the day of the surgery, first of all, we have to probe. We confirm the 3 millimeters of distance between the gingival margin and the crestal bone. After this tooth was loosened, either using periodontal or mini levers, we extract this tooth using a traumatic forceps. Take a look here at the maintenance of the soft tissue position right after the tooth was extracted. In this step 3, we always do a confirmation of the buccal palatal measurement. And take a look here. This is just a double check because we have already performed over the CBCT scan in this case. As we have 7 millimeters, this is the real life. It was confirmed 7 millimeters. The implant to be selected must be 4. Step 4. Careful curettage of the socket. Take a look at these curettes, what we call serrated curettes. This serrated curettes kit has 3 different sizes, small, medium, or large, that can be used not only the tooth to be extracted, but the dimensions of the periapical or periodontal lesion. We start doing the curettage using these curettes in order to remove the granulation tissue and the remains of periodontal connective tissue. Our goal here is to clean the socket as much as you can. It's recommended to do a plant of irrigation to clean this area as much as possible. And you can insert the tip of the surgical aspirator to go until the end of the socket to remove the granulation tissue and to clean the socket as careful as possible. At this moment, we measure the gingival thickness using a caliper. And pay attention that we have around 1 millimeter in thickness. This is what we consider a thick periodontal biotype, a type 3. Using this caliper, right after the tooth was extracted, take a look at this video. It was confirmed 1 millimeter in thickness. And we went underneath the soft tissue 3 millimeters below gingival margin because over that position we had the presence of the crestal bone. Step 5. Implant placement. The implant has to be placed in the palatal wall anchorage. First of all, take a look at this CBCT scan and pay attention to the shape of the socket. We never go into the end of the socket. If you do it, the tip of the implant is gonna be stopped outside the bone. So we never use neither the end of the socket nor the middle of the palatal aspect. The right position of the initial site preparation should be performed in the coronal area of the palatal aspect. And this is the right inclination of this first drill. And this initial site preparation should be made between 5 to 7 millimeters from palatal crestal bone. Our reference is the palatal crestal bone, not the gingival margin position. This is the right inclination. The first drill has to be inserted with 45 degrees of inclination, almost touching the gingival margin. This is just a picture that guides you the right position of the first drill to be inserted inside the palatal bone. After we go deeper inside the bone, pay attention to the buccal palatal direction of this first drill in place, exactly in the middle between the cingulum and the incisal edge. This is the first entrance of the drill with the inclination to the buccal aspect. As soon as you go inside the bone, between 1 and 2 millimeters, we push the contraangle against the palatal wall. This is the first hole. This is the most important one. This picture was taken right after we did the first perforation. And we insert the guide pin, to know exactly the position of the implant that's going to be placed in the mesial-distal aspect in the buccal palatal direction. This is the right position of the implant to be placed, and we never go to the end of the socket. Never. So you can follow the right position of the site preparation in the mesial-distal aspect and the buccal palatal aspect. After that, we can go until the planned length. But every single drill that we change, increase the diameter, the first inclination should be made in the same that we did in the first one, with an angulation of around between 40 and 45 degrees. As soon as you go inside the hole, we push the contraangle against the palatal wall, always seeking the palatal wall. If you don't do this, you can trim the bone at the buccal aspect. This is our first recommendation, to begin the site preparation with a slight buccal inclination. And we increase the diameter of the drills following the manufacturer instruction. And I recommend you to do an under preparation, but it depends on the macrogeometry of the implant. If we use a hybrid implant, for example, it's recommended to do an under preparation. And if we use a taper implant, it's not necessary to do that. So after implant site preparation, the implant is going to be placed, but the first inclination is the same, slightly buccal inclination. As soon as the implant go inside the hole, we push the contraangle against the palatal wall. And here, and we insert the implant, and we increase the torque of the engine, and the implant is going to be left with this mark, laser mark, coincident with the gingival margin. That means that the implant is going to be placed 3 millimeters from the gingival margin in the apical direction. So in this case, the length of the implant was 13 millimeters. And from the gingival margin, we use the reference 16 millimeters because we intend to leave the head of the implant 3 millimeters from the gingival margin in the apical direction. After the implant was placed, we remove the insertion key, and you can see here the gap between the implant surface and the crystal bone. Let's focus a little bit more about the 3D position of the implant in the apical coronal direction. Remember, the implant must be placed 3 millimeters from the desired gingival margin. That means when we have a slightly gingival recession or the increasing volume of soft tissue in the coronal direction, our reference is the contralateral side, and the implant has to be placed at the enamel cement junction of the contralateral side. Talking about the buccal palatal direction, the implant in the center of the socket means that we are going to have a thinner buccal wall and, of course, a thinner soft tissue. You can see through the transparency of the soft tissue, a thin periodontal tissue, you can see the head of the implant. That's why the implant has to be placed always seeking the palatal wall. Our goal here is to have a thicker buccal wall and thicker soft tissue. This is our dream of soft tissue thickness around the implant. So the implant was placed, we check in the patient's mouth the 3 millimeters of gap at the center of the implant, at the mesial and the distal direction. Just a confirmation of the gap in all directions. So you can see here 3 millimeters of gap to be filled because we are treating an intact socket. So this case requires the gap filling. Step 6, the construction of the provisional crown. You can use here a composite resin or a prefabricated acrylic resin tooth. During the construction of the provisional crown, we define the critical and subcritical contour. Critical contour is this black line that should be coincident with the anatomical contour of gingival margin. And subcritical contour is going to be made ½ millimeter above the first mark. And above this area, we have the subcritical area. So the anatomical contour of the provisional restoration, the ideal emergence profile, should be made from the subcritical contour to the head of the implant. This is our provisional restoration as soon as we finished. From the side view and from the palatal aspect, you can see here the hole that was made in between the cingulum and the incisal edge. And we have to leave this concavity, an under contour in the proximal aspect and in the buccal direction. Step 8, the selection of appropriate chisel. We have to use these chisels according to the amount of bone required. To harvest bone graft from the maxillary tuberosity, we need previously the clinical assessment through digital palpation plus clinical evaluation and X-ray and CBCT scan from this donor area. Through this X-ray, you can see a good amount of available bone in both tuberosities, the right and the left side. Now it's easy to make the decision. Of course, we always prefer to use the same side of the problem. Through this axial view, you can see the bone available behind the second molar, and we have 15 millimeters in width and almost 9 millimeters in length. And you can go, of course, behind the second molar. Here you can see the case. We are doing here a posterior anterior crestal incision, and it was performed right after that an intrasuccular incision. If the bone is placed in the buccal aspect, we don't need to raise the flap to the palatal aspect. This is why we are doing just the flap reflection to the buccal side. And it's recommended to do here the irrigation in order to see the field as much as you can. And here doesn't matter the shape of the bone. This is why we are using here the curved chisel, but it could be used here a straight one in order to take a block bone, because this bone is going to be crushed to reduce the size of the particles. So it doesn't matter the shape of this graft. After this graft was fractured, you can see here the block bone, but it's not very common to see a block bone like this without a high vascularization. As soon as the bone was taken, we insert a gauze and we ask the patient to bite. We insert this bone inside the container. This is the block bone that's going to be crushed. In case like this, that we have a low vascularization, it's recommended to add blood from the tuberosity in the bone graft. So this block bone was crushed using a rounder. Pay attention that we are reducing the size of the particles as much as possible. And after that, we added blood from the tuberosity in the bone graft. And we keep it there for some minutes, just a couple of minutes. Step 11, the insertion of the particulate bone graft. To do this, we first insert the cover screw over the head of the implant. and we start introducing particulate bone graft in the gap. First of all, to pack bone graft at the apical part of the defect. And after that, we pack this particulate bone from the middle third to the coronal third. And pay attention to that we have two different tips, the small diameter and the big one. The small diameter we use to pack graft from the apical third to the middle third. And the big one we use to pack graft from the middle third to the coronal third, till we completely fill the gaps. During bone packing, we can add blood in every single step using a syringe, as you can see here. And we carry on packing bone using a bone compactor, and we cannot leave any empty space in between. This is why this task should be done as careful as possible. So the more vascularization in the bone graft, the better the bone graft incorporation. And after bone filling, we check again the 3 millimeters of gap filled with particulate bone harvest from the right tuberosity. And you can see here the 3 millimeters of the new wall in the middle of the implant, at the distal aspect and the mesial aspect. As you can see through these three pictures, exactly in the center, in the distal and the mesial direction. Step 13, the installation of the screwed provisional crown. Right after we finish this task, the bone filling, we immediately insert the provisional restoration that was already finished. So we install this provisional restoration over the implant with ideal emergence profile. We screwed. At this moment, the cervical area of the provisional restoration can't pressure the soft tissue. Here, right after this provisional restoration was inserted over the implant. Here we can make a comparison before and right after this procedure was finished. And this is the suture in the donor side. This is the last step of the technique. Number 14, the suture of the donor area using simple stitches. In case like this, the patient won't complain on swelling and pain. This is the post-op after 2 days. Everything is going quite well. Around the provisional restoration, the soft tissue is quite nice. And you can see from this occlusal view the quality of soft tissue. And here the post-op is just 2 days after we apply this technique. In 7 days post-op, the soft tissue is much better. The color of soft tissue very similar to the neighboring teeth. And pay attention to the quality and color of the soft tissue. The X-ray and the CBCT scan, the sagittal and the axial view. I want to call your attention that the bone was placed above the head of the implant. So the bone was packed using a bone compactor in order to leave only the entrance from the provisional crown installation. And through this CBCT scan, take a look at the 3 millimeters of bone at the buccal aspect and the bone that was placed above the implant platform. As you can see here. This is before and after our planning, and after the execution, the implant was placed exactly in the place that it was planned before, and the gap was respected. 3 millimeters of gap plus 4 millimeters of implant diameter. Take a look at the main difference between the crestal bone thickness before and after this procedure was applied. We have 3 or 4 times thicker than the beginning. After 3 months, after soft and hard tissue is healed, and pay attention, make a comparison between the right and the left side. And take a look at the thickness of the bone grafted in the right central incisor and in the left central incisor. So, after 3 months, we removed the provisional restoration to evaluate the soft tissue quality and thickness. We measured the gingival thickness, and you can see here over 3 millimeters in thickness. Just make a comparison. In the beginning, we had 1 millimeter in thickness. Have a look at the thickness of soft tissue. Make a comparison between the right and the left central incisor. And the bone graft is completely remodeled over the implant platform. From our planning to the execution. Remember our planning? And now let's have a look if we did right. The implant was well placed following our planning, and we respect the rules about the coronal apical direction, the 3 millimeters in thickness, and the correct implant diameter selection. Pay attention here to the magic square. First of all, again, the importance of the correct three-dimensional position of the implant that's represented in the red color. The purple one is the bone thickness, it's around 3. The green, the coronal apical direction, the implant was placed 3 millimeters from gingival margin in the apical direction, and the gingival thickness, and we always find equal or more than 3 millimeters in thickness. Most of the times we will find more than 3 millimeters in thickness when we apply this protocol, regardless of the thickness of the periodontal biotype. So in 4 months, it was taking the impression at this step. So we removed the provisional restoration, and you can see here the peri-implantar soft tissue. Here, right after the implant was inserted and after 4 months, we have the biotype conversion and improvement. We have a thick biotype, and here you can see a relevant thickness of this periodontal biotype. So it was taken impression, it was made the final abutment, a zirconia abutment that was cemented over the link, the titanium abutment. This is a customized abutment. As soon as we insert this customized abutment over the implant, through this occlusal view, you can clearly see the quality of soft tissue around the implant and around the neighboring tooth. So this neighboring tooth was prepared to receive a porcelain lens, and here I want to call your attention to the quality and thickness of soft tissue around the implant. It's much better than the left side. It's thicker than the left side. The final restoration was delivered in both central incisors, in the natural tooth and the implant placed. Now we have 3 main topics to be evaluated in the soft tissue. We have to evaluate the color, the texture, and the maintenance of the volume of soft tissue. And we have to respect these rules. Here you can see the tissue stability. Tissue stability means the bone tissue stability and the soft tissue stability. We have the maintenance of the bone level around this implant, and we have the maintenance of soft tissue around the final restoration. The follow-up after 4 years, you can see here the soft tissue stability. If something went wrong since the beginning, we would have some problem because this patient has a high smile line. Imagine if we have here in this case a gingival recession or the papillary loss. It's very difficult to deal with after this problem appears. That's why I recommend you to apply the right protocol to replace tooth, especially in anterior zone. This is why I believe that when we use bone from the tuberosity to fill the gaps, regardless of the thickness of the periodontal biotype, this is the outcome that we are looking for. We've already seen the IDR protocol in intact socket in the analogical way, either using a free handle or using a surgical guide. Now let's focus in the same protocol using a guided surgery. That's what I recommend you. Regardless of the tooth to be replaced, if you have the opportunity to use guided surgery, this is our first preference. In this case, this patient came to us and he presented a problem in the upper left first premolar. But take a look that the gingival architecture is in the right position. And through this X-ray, you can see the bone loss in the mesial crestal bone, but we can also see two different problems: a large periapical lesion and the root resorption. Through this CBCT scan, it was confirmed here the presence of the crestal bone at the buccal aspect, so we are going to treat this case as an intact socket. The tooth was extracted, a very difficult tooth extraction. This is what we recommend in case like this, to do a root section and to remove the roots one by one. Our goal is to keep the interdental septum between these two roots. After this tooth was extracted, it was inserted here a guide. We check through the special windows the good adaptation of this guided surgery over the teeth. Just a quick review. During our planning, we can check not only the 3D implant position in the buccal palatal direction and the mesial distal direction, but we can also plan here the width of the gap to be left between the external aspect of the implant and the inner part of the soft tissue prior to the surgery, and of course the depth of the implant inside the bone. After the expansion of the guide over the teeth, we start the site preparation. First of all, we use a 2.0 drill because our goal here is to insert the implant with a 4 mm diameter. After 2.0, we use a 3.5, and after that, a 4.3. This is the X-ray that was taken right after final drill preparation. And we install the implant using the guide in position. This is what I like most, to use the surgical guide since the beginning till the implant in place. After the implant was placed, we remove the implant driver. We remove the guide from the patient's mouth. And here you can see the implant in place and the gap in the facial aspect. Here you can see that the space between the external aspect of the implant and the inner part of soft tissue was respected following our surgical planning. Here we were planning the gap at the buccal aspect. So the bone was taken from the left tuberosity. We crushed this bone to reduce the size of this particle as much as we could. And we pack bone in both sides, in the buccal and the palatal direction. And we also added bone in the mesial and the distal side. Just a double check of the 3 mm of bone filled at the buccal aspect. It was performed, the provisional restoration, using the same crown from the patient. We just added composite resin at the cervical area, and it was performed here the ideal emergence profile. Right after this provisional restoration was placed over the implant, take a look at the length of this crown. It's shorter than the neighboring teeth in order to protect this tooth from the occlusion. This is the immediate X-ray. Pay attention to the tip of the implant and also the head of the implant. We have bone above the head of the implant. And here you can see the correct three-dimensional position of the implant, exactly in the middle of the crown. 3 months after this procedure was applied, here you can see the soft tissue is completely healed and the bone tissue is healed as well. We have the bone repair finished all around the implant. So it's time to take the impression and to make the final restoration. But let's focus in these two images, the clinical image before and after 3 months. And take a look what happened with this gingival margin position. We have the corneal displacement of soft tissue that was obtained through the implant position, the gap at the buccal aspect, the bone reconstructed, and the ideal emergence profile. This is the CBCT scan that was taken after 3 months. Take a look at the thickness of the buccal wall, from the mesial to the distal aspect. After 4 months, we removed the provisional restoration to evaluate the soft tissue thickness. And you can see here the maintenance of the anatomical contour of soft tissue and the maintenance of the papillary height. Here, the outline of gingival margin and the papillary height still remain in the same position, the mesial and the distal aspect. Just make a comparison. Before and after 4 months, we have the biotype conversion. We start with a thin periodontal biotype, and now you can see a thick periodontal biotype. So you can notice the improvement and the periodontal biotype thickness. And we did evaluation of the maintenance of bone graft thickness. And we can superimpose. And you can see here that the bone wall is still remain in the same position, but with a relevant thickness. Just make a comparison before and after 1 year. I want to call your attention to the increasing in thickness of this new buccal wall, 3 or 4 times thicker than the beginning. The IDR treatment protocol for intact socket was presented using conventional surgical guide and guided surgery. The outcomes obtained with the use of autogenous bone graft reinforce the idea of the preservation of the anatomical structures of the hard and soft tissue architecture.